just getting ready today to start our last full day of content on our Learning Collaborative on Risk Management and Risk Adjustment. The next time we get together, we'll be hearing from all of you on your final projects and wrapping up what hopefully has been a pretty valuable session for you. I'm going to be walking us through today with some discussion on the, that's who we are. You guys know who we are. I'm going to be talking us through some of the homework questions and then talk about how the Starling approach to risk management is being used by health centers and safety net providers around the country. And we're really going to focus in three main areas. We're going to talk a little bit about case management, population management, and care coordination as strategies for risk management. So let's start with the discussion around the homework. And thanks again to those of you. You guys are a great and responsive group, and we really appreciate hearing from you guys. Every time we ask you to respond, you do, and so we appreciate it. So, you know, a big piece of approaching risk management is really understanding who the patients, the population of patients are that you're working with, which is why we wanted to sort of get a little bit of a better understanding of what you guys are doing at your organizations around population health management. But we know this is a challenging issue, and so I think we've got one respondent who pretty much indicated what we see a lot, which is that they'd love to be able to use that data, but it isn't always easy because our hospitals and the payers aren't necessarily forthcoming with some of the key data sets that would really inform that population health approach. And so having access to admit, discharge, and transfer data, having access to claims and utilization data, just not something that is always possible. Another group indicated that, you know, tracking key measures is an important part of what they undertake when they're looking at their patient populations. With regular use of monthly registries, which is a great tool. It's a kind of a fundamental cornerstone of any population health management approach. In this particular situation, teams are asked to review those lists and looking to compare improvements in key measures across the organization. But as many of us are facing some real challenges in getting social determinants and social acuity issues factored into some of that as a means of trying to manage those populations and identify some core interventions. And so anyway, I think that's an ongoing challenge that folks can relate to as well. In another case, we have probably at the primary care level kind of a decentralized model, which is that the FQHCs and the health centers are managing the population health information for their patient population, but it's not really going across the network. But it sounds like the PCA and their accountable care organization aren't really using a centralized population management tool. Some of the health centers are using I2I for population management, which the PCA or the network is hosting. So I think that's pretty typical that we see kind of this myriad approach to trying to sort of attack this issue of population health management. So when you are looking at these populations that you think are going to require additional management, where are really your priority organizations? I think this is also very typical that we see a high focus on our chronically ill patients. So I'm unsurprised to see things like diabetics, hypertension, obesity, and then some specific areas around wellness like blood pressure, tobacco cessation, and well-child visits. Also really important wellness process measures. And then we focus here, it says like on the last one around just really looking at some of those compromised low-income and vulnerable populations that safety net organizations are typically interacting with and identifying strategies around. So what kind of data and reporting systems are you relying on? Most of us understand the value that our EHRs play in these roles, and all the respondents really hit on that. And some of us are working also with additional analytics and aggregation tools like I2I and Bridge IT, which help pull that information together so that we can really look at the total population of patients. The challenges that folks are dealing with as they look at this, completely, again, not surprising. We know that a lack of access to data or incomplete data is one of the biggest challenges that we get when trying to fill out the broader picture of what we're looking at. And so inconsistent access to data, whether that's because the data systems just don't exist or because we don't have a good way of intermingling things like payer and utilization data in with the reporting that we currently do through our EHR. We know that this is a central challenge for you guys. Okay, so before I move on, I guess any other thoughts or questions that you guys might have about some of the homework questions or some of the challenges that you guys have identified at your organizations around being able to really use data to think about who your patient populations are and how you might target intervention. So just before I jump in, just curious to see what your experience has been on the ground. Okay. Well, I'm going to talk a little bit about guidelines for risk management, and before I do that, I just want to do a quick review. I know we're nearing the end of our time together, but just a little bit of review of how Starling approaches the issue of risk. So risk adjustment is really a tool that payers use to identify how much funding is going to be directed towards a specific population of patients. As we know, it's a really critical step in the any of the value-based payment models that we're being faced with, and many are more than ever are really asking us to be cognizant of how total cost of care fits into that. Quality measures, social determinants of health, and other factors might play into the risk adjustment of the patient populations, but those models, as we know, are still evolving, and our ability to work with payers to really partner on effective risk adjustment models and mechanisms are a continuous challenge for us. Risk stratification is about really being able to use tools to be able to be proactive and somewhat predictive about which patients might require different support services and different types of interventions. So being able to, provide information around risk scoring that allows us to essentially triage our intervention models is really what risk stratification gets at. And then the risk management aspect of this is what those interventions and care coordination models look like. So, this, and we're going to talk, this is really the focus of today's conversation, and we're really going to focus on, what are some of the approaches here and how do we develop a model that allows us to really, help support the cost and quality goals for those patient populations. So when we look at a model for how we think safety net organizations should be thinking about risk management, there are really six main components that we think that health centers and safety net providers should be focused on. And we're going to talk about these in more detail, but just really quickly, the first is really how do we put mechanisms in place to be able to identify our patient population, really understanding who that patient population is so that we understand how they might be sensitive to certain interventions. The second important component of this is being able to use a myriad of evidence-based strategies that allow us to really target interventions that are patient-centered and build upon best practices. The third focuses on building a care plan that can be monitored within your existing health IT and data systems. And that's important because you need to be able to use the data that you have at your disposal to help support that. Sometimes that means building that process out, the data infrastructure out more. But regardless of whether or not you have a perfect data system, it's really critical that the care planning is really informed by data and really lives within the data systems and the electronic medical record systems that you have. Another important aspect of all of this is ensuring timely access to care. We know how important this is in terms of being able to really keep our patients engaged and focus on interventions that are both going to be timely and impactful at the patient level. And so we'll talk about that a little bit. And then finally, this idea that all of this is related to just a continual transformation of our internal operations. We're being asked to look at risk management and the management of our patient populations in a very, very dynamic environment. And there are several things that we think are important for you guys to think about as you kind of enter that mindset of sort of, continuous quality improvement, both at the operational and at the clinical level. And then ultimately, going across all of these is this idea that which many of you I know are facing, which is that these risk management approaches are only as good as our ability to sustainably provide them. And so part of what we think is especially critical for safety net organizations is that they be thinking about how their existing payment models or models of payment that they might be considering with different payers in their market, how those models are really going to support them in their endeavors around risk management. So let's just talk about these in a little bit more detail. So identifying your patient populations. So during the course of this session, this learning collaborative, and we've talked a lot about how important it is to be able to identify the patients that that are a high priority to the payers, and identify patients that are going to be targeted for our various strategies. And this is really, when we talk about identifying your patient population here, we're really talking about moving from, so now you've identified them, and now we have to get them into these risk management arrangements. And so this is really around a transition for that. Oh, looks like we're having technical. Oh, we're getting back on. I don't know what's going on. And I mean, that makes sense. I mean, the first step is really to identify them, and then the second step is to figuring out how we're going to best manage and support those patients. We know that it's important that we think about the use of data in this process. So claims data, EHR data really helps to sort of parse out who we're focused on. There could be key triggering events, for example, a hospitalization for a patient with, congestive heart failure, for example. Their transition out of the hospital would potentially be a triggering event for care management interventions, or the use of particular diagnostic codes. So all of those things can be used in the risk scoring of the patients and really help to identify who the patients are that would be we would engage for various risk management strategies. In some cases, payers are going to identify those patients and populations for you. So you might be, for example, involved in an arrangement with a payer to do a specific set of interventions for your age-blind disabled Medicaid populations. Many of you might, for example, be involved in patient-centered medical home groups where the medical home pilots where the payers themselves have given you a list of patients from your payer roster who is, with a certain set of risk factors that the payer wants to remain sensitive to. The Medicare Shared Savings Program is another example of that. That patient population is identified for you through the attribution process with the payer, and you may subdivide those patient populations based on your interventions, but the payer really is driving the conversation and setting the parameters for who the larger population is. We also think it's important to realize that to some degree, we understand that you know your patients better than anybody. And there are going to be situations where providers are going to identify patients that they think are going to be responsive to various care interventions and risk management approaches. And we think that's really important, that, risk scores are important and looking at a wide number of variables is critical, but the providers themselves are often going to know these patients better than anyone, and making sure that there's flexibility in those models to allow providers to play that role. And then finally, as we get toward more advanced models of using our data, predictive modeling is something that plans and payers often will use, and it's another piece of the overall puzzle in terms of how those patients are identified. Any questions or thoughts about how these patient populations are identified? Any challenges you might have encountered in trying to identify these patient populations? Okay. Oops, I went backward. Sorry. All right, so using evidence-based strategies to target patient-centered care. Now, there are so many great strategies, and I think one of the things that the safety net has been really, really scrappy and nimble about is really looking for opportunities to leverage evidence-based and best practices and apply them to their patient populations. So this slide could actually be, we could do an entire, probably learning collaborative just on this topic. So what we've tried to do is just kind of enumerate out a few examples that we think are important for us to think about. And we know just from having gotten to know you guys over the last couple of months that you're looking at a lot of these. So this should be sort of an affirmative part of today's session. But obviously one of the most critical pieces around really targeting these risk management activities is having a care coordinator or a care manager who's identified and whose goal really is to, manage and respond to what the individual's needs are. And they really have that role of not only setting the clinical goals for the patient, but also helping to coordinate their care. And I think, IHI and HRQ, many organizations have just lots of great information about how to really successfully set up the work of your care managers. What are some resources? What are some templates? What are some examples of the role that those care managers can play? And those care managers can be staff across many different domains, and we'll talk about that a little bit later. But it's, depending on who your patient population is and what your intervention is, the care manager might have different letters after their name or a slightly different job title. But at the end of the day, what's really important is they're really that patient's one-to-one contact. They're setting those goals and taking that liaison role. And another interesting and important component of all of this is, how are we really working in our risk management programs to really engage patients? And there are so many different ways to do that, many of which are technology-based, and but some of them are low tech as well. But strategies that we know a lot of you are looking at and a lot of your peers around the country include things like telephonic, home visits, maybe texting programs, patient portals. I mean, there are just a lot of ways to be thinking about how to really engage the patient in their own care planning. One of the critical areas that we think needs to be continuously reviewed and fine-tuned is this issue around effective empanelment strategies. So, and again, we've got some great national resources on best practices around empanelment and how we really support the care teams and support the patients in those care teams, how we're using, data to prop up our empanelment strategies, and our panel management is critical. And then, of course, care transition planning, coordination across the system, including social services, particularly with our patient populations who tend to be facing many more obstacles and challenges in the sort of, sphere of social determinants. That's really the heavy lift of the care manager, but ultimately needs to be embedded into the entire strategy. So really thinking about how that kind of care planning can really support your programs is critical. And then finally, use of evidence-based clinical pathways, evidence-based guidelines. building that consistency across your model so that there is a continuous focus on the fact that the activities that are being undertaken are underpinned by those important best practices, and essentially are providing a way to sort of bring some scalability to the efforts that you're providing to the patient. So I know I didn't list all of the evidence-based strategies around care coordination and risk management, but we tried to highlight some of the ones that we think are the most critical. Are there other sort of best practices that you guys are utilizing in your care management that you think are important to highlight here?
Hi, this is Sue calling from St. George, Utah, Family Healthcare. I just have a question on the effective empanelment strategies. So we have a pretty, we have a method that we would empanel patients, but not a real great way to manage that or delete inactive patients or track those who are deceased or those kinds of things, or see if they would do better in a different panel. What kinds of resources are available to help us with that?
Sam, I know you're on the line. Do you want to jump in on this at all? Because Samantha Jones from our team really does a lot of the work that we do around clinical team development and things like that.
I think that one of the best empanelment sort of resources that we've seen, I think we may have shared it on a prior call, but the Safety Net Medical Home Institute, Sue, has a bunch of different sort of resources and approaches to empanelment. So I can send you that link after this call, and you can let us know if that helps at all with your specific situation.
Amanda, this is Andy. I'll just add, working with specifically the Medicare Shared Savings Program, realizing Medicare is probably not your primary focus, but some of the key findings were that the plans often do have some of the precise data that you're talking about, essentially the deceased data, moved or gone elsewhere data, disenrollment data, and making sure that if you decide to enter into any kind of value-based contract, that ultimately will have to be defined by a population under management that you negotiate essentially to get that data in relative real time. And the reason I mentioned the Medicare Shared Savings Program is because I'm proactively involved in helping organizations download and then implement their data sets, and one of the most valuable pieces of data we get every month is which patients are no longer actually in the program, whether it is because they've become deceased or for some other reason. My only other just personal experience in managing this type of information and data is until you have some kind of risk adjustment approach, it's really hard to do any sort of apples-to-apples panel management. And although everybody asks and everybody would like it if there was a one bulletproof, perfect risk adjustment or risk stratification approach and a perfect staffing level for the number of patients that can be empaneled to a provider within each risk category, the reality is that we're not, as an industry, not that mature. So most of the organizations that are doing that well are actually just taking a first pass and then adjusting as they go. And it can be pretty insightful to really start to look at, once you've broken patients into 4 or 5 categories, how the variation across your providers and care teams looks, and pretty quickly you can start to figure out what the appropriate allocation is once you've risk stratified. If you try to do that on the whole population, it's nearly impossible because you'll just never get to severity in a meaningful way.
Thanks, guys. Appreciate it, and thanks for the question. So, and an important piece of this obviously is around developing those care plans. It's great if we have the ability to integrate advanced data and health IT as a component of risk management. And what do I mean by that? That is, that means not only data that you might have in around the clinical data that might be inherent in your electronic health records, but other types of data related to claims and utilization or care coordination data. A really critical piece of putting those pieces together to have a patient-centered, patient-driven plan. As you guys know, having care plans that include milestones and targets is critical, and making sure that the care plan is inclusive of some of the most important aspects of the risk assessment that you have undertaken in order to properly target interventions for those patients. So that may include clinical risk assessment, but there also could be issues related to their social determinants that would be critical for the care team and for the care coordinator to understand as they're working with that patient and setting those goals. Sometimes practices are using sophisticated technology tools to help them support this, like care coordination software or population health management tools. But sometimes they're quite literally just pulling things out of patient visits and the EHR and populating it onto a care plan. In our opinion, it is much more effective when those care plans are somehow embedded into the EHR so that providers across your service spectrum have the ability to go in and sort of see what's going on with that patient. So we know that you guys are already utilizing many of these models, but we just wanted to highlight, why we think it's important and the role that the care plan makes or takes on in terms of this work is really central. Ensuring timely access to care. So, this is something that I think safety net providers understand maybe even better than other parts of the healthcare delivery system, because we understand kind of the volatile nature of really trying to engage our patients and making sure that we keep them involved. And so obviously a core component of anything that a care manager or care coordinator would be doing is really to schedule any follow-up and coordination, both with other providers as well as with the patient and their families. Taking on the role of referral management is also something that is oftentimes a central piece of a risk management approach. And so having designated staff or designated functions that help to support that are critical. Similarly, making sure that we have relationships with community-based services and have the ability to not only do outreach through those services, but also referrals to them as well. It's just another way to be able to take services out into the community, create linkages with CBOs that are providing essential non-medical services to our patient populations, and really strengthen essentially the safety net around those patients. In some cases, health centers and safety net providers have looked at open access scheduling as an option for this. And really, I think every organization is different. The goals and objectives around your scheduling and the infrastructure around that are unique to your organization and your patient's needs. But we have seen this emerge as a best practice that we think is helpful as organizations start to explore opportunities around this. And so we think this is it's something for folks to consider, as is modification of hours in order to be able to really meet the needs that patients might have. Does this mean throwing in an extra Saturday a month? Does this mean after-hour care, or even a home visit model or something like that, where you're focused on expanding out access opportunities? And then finally, being able to educate patients on how to use and access care most efficiently. So, helping them understand that you don't need to go to the emergency room when XYZ present, that there are, ways to sort of treat, that they could help triage that themselves and making sure they know when they need to go to the emergency room. When is it important to see their nurse practitioner versus when do we have to go see a physician, so those kinds of things, and really taking on an active role and helping them understand that. Okay, so transforming internal operations. So this is another one that is a really big catchment area, but we think it's really important to these general strategies, and we want to just highlight some of the things that we've seen safety net practices undertake as they go through this care management, building out their care management infrastructure. The first is around designing multidisciplinary teams that support your care model. So depending on who your patient population is, depending on what the goals of your care coordination infrastructure are, your care team may look different. If, for example, if you're dealing with a population with a high incidence of homelessness, there could be different components and different individuals that would need to be in place. If your care model is focused on a behavioral health integration, obviously we would need to have both behavioral and primary care involved on the care teams. So it just really depends on, what the goals and objectives are, but generally speaking, the more multidisciplinary, the better. Constantly looking at different quality improvement efforts to really identify how are the needs of the patient population, the care model, and payers changing what the care team needs to be thinking about. We know this is an incredibly dynamic environment. It's probably only going to get more dynamic as we march into the future with, everything going on with changes at the national level. And so it's really important that we don't get stagnant in a particular model, that we're constantly working together and through our care teams to identify how things might need to shift or iterate. It's always important that we're looking for opportunities for efficiencies and economies of scale and intervention. That's true, obviously, clinically, but we also want you guys to be thinking about how can we do that operationally and financially. So, are there ways we can pool resources? Are there, process improvements we can put in place that really streamline or make particular situations more effective? Those are things that we need to be continuously looking at and thinking through. Making sure that everybody on the care team understands what their role is and that they have the tools that they need to do their job. Often that might relate to different access to data, to different types of data. It could be training. It could be external relationships. It could be any host of things that might be affecting how the care team is functioning, both as individuals and then ultimately as a group. And then finally, we can't overstate this last point enough. It's really, really important that leadership at these organizations understand the importance and around investing in change and supporting this sort of emergent model of care delivery through the care teams and various risk management practices. And leadership has to evolve its thinking as well. And oftentimes they'll be on the front line, working with payers and working with systems and really needing to be able to kind of bridge that gap between what leadership sees as the priorities and what's going to help facilitate the most effective patient care is important. But again, we know it starts at the top. And so really making sure that we can, on the front lines, help arm our leadership with sort of the points to articulate back, but also that we see this as a partnership with leadership and being able to do that and support long-term change. And then finally, the financial sustainability of risk management. There's so many things that go into being able to put models in place that can really support important clinical interventions around care risk management. But it's really important that the providers understand the reimbursement model. So again, another important thing of making sure that the folks that are all engaged in this understand the environment in which they're working. So if the providers themselves don't understand what's reimbursable, how it's reimbursable, the impact it has on finances, we can't tap into their expertise in developing care models that are really going to be supportive of us being able to fully leverage the financial opportunity we have. And so it's really important that those conversations are kind of baked into the planning that we do around our risk management strategies. In many cases, what we see also are organizations that are looking for ways to incentivize providers to do this and do this well with high-risk patients. And so we're starting to see sort of variable compensation programs that are looking at not only compensating providers differently, but the whole care team if those health outcomes are being effectively met. You guys know this, that's why you're in here, but what we see is that more and more safety net organizations are really transitioning toward models of payment that reward better patient management. And so whether you're looking at kind of the most fundamental payments around pay for performance or care coordination payments, all the way through shared savings and bundled payments, it's just becoming really the lifeblood of how we need to be operating. And so gradually testing out different models of payment that allow us to demonstrate over time our increased capacity for being able to better manage these populations is important. Just to kind of put a point on this one, we think this is an incremental step. We wouldn't suggest that groups doing this for the first time jump into a bundled payment or a much riskier model of payment, but gradually over time building your capacity to not only better manage these populations, but demonstrate that you're managing these populations to the payers is going to be important. And central to that is the ability of being able to really monitor your accountability targets, metrics, and incentives across providers. So really being able to look and benchmark how you're faring relative to what the payers expect, and what does that mean relative to the care models and the intervention models you've established. Okay, so we want to now just kind of shift and talk a little bit about what some of the approaches are, and these are to some degree there's no way to have three sides of the same coin, but let's just pretend that there is. These are really sort of all key components of being able to effectively manage the patient populations, and they're intentionally overlapping because so many of the goals and the strategies really hold them in common with each other. So whether we're talking about care coordination, case management, or population health management, there's some things that are really central to the risk management approach. The first is that all three of these, in order to be most effective for the patients and for the payers, really need to be data-driven. And we've talked a lot about that as it relates to identifying who your patients are and benchmarking and monitoring your performance over time. All three of these really focus on being able to target your patients, knowing who those patient populations are that you're going to be directing services and resources to is critical. All three of them in this modern world that we work in, to some degree, are going to have some backbone of IT that's going to be helping to facilitate and organize the activities and the strategies. All three of them are likely to include some component of a care team, and we talked a little bit about that. And obviously, in our models, we're always thinking about the patient-centered nature of the interventions themselves. So let's talk about the population health management as a strategy for risk management. Unfortunately, I left off my citation, so I'll clean that up and get you guys out another example of this, or the citation for this. But population health management is the combination of all available sources of data relevant to the health of a population for the purposes of analysis, so that the analysis then can create a prioritized list of actionable steps that can be taken by a coordinated team of caregivers to improve on the outcomes, cost, and care experience of the individual people making up that population. So the focus here is really, how do we take all the data that we have and put together a big picture roadmap of where we're going to apply resources to support these patient populations. And some of the things that we see as best practices in population health, obviously using data to define who those patients are, looking at the full continuum of care so that there's a big picture of what's going on with those patients, and that it isn't just simply episodic interventions that look at, very myopically at what's going on with the patients. The population health really is driven on, this idea of care coordination and managing care transitions, which we've also talked about, and looking at ways to invest in in-home intervention to engage particularly high acuity patients is a really important strategy that we've seen from a population health perspective, where those particular types of resources have been directed at the highest need patients. And then obviously expanding out our chronic disease management. So case management is a little different, and case management is a collaborative process of assessment, planning, and facilitation and advocacy for options and services to meet an individual's health needs through communication and available resources to promote quality, cost-effective outcomes. We tend to think of case management as being relatively linked to sort of discrete activities. So, like, for example, the idea that, and I've got some examples here, but the idea that you're looking at sort of, specific activities, like, for example, a patient in a hospital, is getting discharged, and so the case management is really around, the precipitating event is the discharge from the hospital. So there's a link, I think, to sort of discrete triggering events that will be strengthened through particular focus and coordination at the case management level. And so the example, I keep going backward. I'm sorry, you guys. The case management example that we provide here is a model that comes out of University of California, San Francisco's Medical Center heart failure case management program. So in this particular case, what they've done is they've put in place a case management program to specifically reduce readmission by elderly heart failure patients. So again, a real focus on managing these patients at the point of discharge and helping to connect them to a care team that can assist them once they're out of the hospital and have made that transition. And so by targeting specific case manager resources at the hospital level, they're able to help facilitate that as the patient's transitioning out. And this data is a little bit old, but I think it's still important, in terms of the study that they did in looking at this program, is that they had a 46% reduction in the 30-day all-cause heart failure readmission, which is, a significant drop from where they had been previously at 24%, 35% reduction in the 90-day all-cause, and then 40%. So 40% in 2009 to 26% in 2002. So what we see is, by really focusing these targeted case management approaches, a real impact on how these numbers are being affected, and how the patients are basically staying out of these cycles of continuously being readmitted. Okay, I'm having problems moving my screen forward. AJ, I don't know, can you? Okay, thank you. I think I'm skipped too far, though. There we go. So care coordination as a risk management strategy focuses on sort of this deliberate organizing of patient care activities across a continuum of providers who are working to support that patient's care. And so that means that patient really has sort of that internal advocate who's helping to line up what their preferences and needs are and communicating across a care team and a continuum of providers to be able to bring that care to the patient. Okay, if you could advance, please. I've somehow lost my ability to advance. Sorry, AJ. Okay. So AHRQ has done some good work in terms of breaking this out in terms of the what some of the strategies are. There's some of the broad strategies we've talked about, working, through teams, care management, health IT, and patient-centered medical home. And then some of the specific things that help support this include things like, really putting strategies and mechanisms in place to be able to share knowledge across the healthcare system, things like the use of HIE or whatnot. Another important strategy for this, and we've talked a lot about this, is this idea that we need to have transitions of care that are thoughtfully planned out, that patients are part of the goal setting to identify and assess and address the needs that they have, that we've got mechanisms in place for effective monitoring and follow-up, and that we're, constantly looking to link up with the other types of community resources that the health center patient or the empaneled patient might require. Okay, Andy. So we talked about this a little bit earlier when we were thinking about who should be sitting in the role of care coordinator. And, we just want to kind of highlight this point, and I know this is maybe somewhat obvious, but, we really want you guys, as you're thinking about what models for intervention are, not only to be thinking about who should be on those care teams, but who is really best suited to function as the care coordinator for that patient. So, for example, if you've got a patient whose issues that are presenting are most focused on mental health, then the care coordinator skill set would likely be somebody like a social worker or a behavioral health provider. If that patient was highly medically complex or frail, the care coordinator is likely to be a nurse manager or somebody who functions in that capacity with the nursing perspective. And if the patient's main issues really center around social instability or lack of social support, somebody who sort of, can fulfill the role of care coordinator would include things like a social worker or even a community health worker. So again, just really challenging you to think about, who's the best person to be connecting with that patient, in order to best manage and support what their care coordination needs are going to be. Okay, Andy. So here's an example of, out of the safety net that we think is a good one, which is the, and some of you may be aware of some of the work that's come out of Oregon in terms of some of the approaches that they've taken in terms of coordinating with payers and safety net providers, and this is a good one. So in this case, Care Oregon has a high-risk Medicaid and dual eligible pilot project where they're putting together care management teams comprised of RNs, behaviorists, and what they call healthcare guides, which are essentially their care navigators, to provide service coordination among the various provider settings. And in this model, what they're doing is really coordinating access to both, pharmacy and medical equipment, and promoting and supporting the role of the primary care home relationship. So making sure that those patients are empaneled to the primary care home and that they have basically a care navigator who's helping to facilitate that for them. And the nice thing is they've been able to really demonstrate the impact that this has had. A small decrease in total cost of care at 2.4%, even though that seems small, that's still pretty significant in terms of starting to really turn some of the utilization patterns around. And you see that, indicated also in the fact that they've had decreases in unplanned hospitalization and ED visits. Okay, Andy. The next one is a model that actually we work directly with, which is a model where you have a network care coordination model. You have a centralized care transition planning. So in this particular model, you have an organization, the St. Louis Integrated Healthcare Network, Community Referral Coordinator Program, actually physically places referral coordinators within hospitals to set up coordination with patients upon discharge. So either working in inpatient units or emergency room interactions, the entire focus of that referral coordinator is to make sure upon discharge that patient, if they aren't already assigned to a patient-centered medical home at an FQHC or health center, is supported upon discharge in that way. And so this essentially helps to kind of reaffirm the PCMH model and get those patients effectively scheduled to see a primary care provider upon discharge. In this particular case, the referral coordinators have access to the scheduling screens for the health centers, and so they're able to actually go in and make those, set up those appointments with the patient prior to their discharge. They work with all 7 area hospitals that are in place there, and at this point, the funding to help support those positions has come from the hospitals, because both the hospitals and the FQHCs that are in the area have seen that benefit, and so they've been able to kind of centralize the resources so that not every single health center has to have somebody sitting in an emergency department or a patient triage center at a hospital, but instead you can have one centralized support service that's providing that for all. And it's been highly effective in terms of being able to get them connected with their PCMH and reduce readmission. Any questions on that? Okay.
Amanda, this is Tricia from DCPCA. Do you have contact info? I think at one point I did get info from St. Louis from a NAT convening or something, but I haven't been able to put my hands on it. Do you know of a contact for that particular model?
Yeah, we can certainly send.
Yeah, I think that could be a really good fit here, because the health centers really want to do the care management, direct care management piece at the local level, but this is an issue for them. So,
yeah, we'll certainly get that out to you, Tisha. No problem.
Thank you.
Okay, another example that we've worked directly with, and what we, one of the reasons we like to share these examples is, just because every community is a little bit different. The types of, local resources that you have available, the local preferences you might have, like Tricia was just saying, tend to vary based on what your patient needs are, what your relationships are with health systems and payers. So what we're trying to do really is just kind of give you some examples of what this can look like. This is a different model that we've worked with, which is a statewide model, but again, a somewhat centralized approach to care management that still gives individual control to the practices themselves for the day-to-day work of the care coordination activities. So in the state of Vermont, One Care Vermont is a statewide ACO that serves the Medicaid population, the Medicare population, and the commercial population. And prior to One Care really expanding its footprint in that way, the state of Vermont had separately been funding an infrastructure of community-based care coordinators across the state, with this idea that, by supporting positions in a regional level, care coordination could be better easily facilitated. Every community has these community care coordinators in place, and many of them sit at federally qualified health centers and other safety net care delivery sites. So the funding for that is separate, from what goes on with the ACO. However, what the ACO decided to do was to really build upon that infrastructure. And so the training and the model of care coordination was essentially promulgated through the ACO based on all the important work that had been done through a very broad planning and a process at the state. So they were then able to add additional levels of care coordination strategies that built off that model that the state had built, but all of which still relies on local implementation. So, so even though the care coordination model is somewhat decentralized, the clinical and the financial outcomes are managed at the ACO level and against the network's goals, and shared savings is tied to those outcomes and adherence to the care model. So this is an example of a state that really took leadership in that, and then the delivery system and the payment system built upon that and was able to support and build upon that with additional layers of care coordination. So, but again, much like the model we just talked about in the St. Louis area, the specific care coordination is still happening at the individual provider site level. But there's a centralized sort of infrastructure and a centralized sort of strategic approach to how to engage that. Any questions on that?
Hey there, this is Megan with the Iowa Primary Care Association. I have a question that's less specific to the Vermont example, but more kind of generally what we've been talking about. One of the things we struggle with here is being able to describe our network's capacity to provide care coordination and care management services. So we've seen this crop up, especially as we've been embarking on value-based partnership agreements with the Medicaid MCOs that recently entered the Iowa market. And so we're being asked to quantify and demonstrate our capacity to provide these kinds of services. And the challenge we keep running into is that our centers all provide these services to some degree, but often that role is wrapped into a larger FTE position. So, and that it jogs my thinking on it, seeing you have some examples on slide 28 where you're looking at matching a care coordinator skill set with the needs of the patient. So you've got a nurse manager who has other kinds of responsibilities that fall under that person's purview as a nurse manager, and one of the things that they do is provide care coordination services. Can you just sort of expound on how to demonstrate this capacity, and maybe if anyone else on the call has encountered similar challenges and kind of how you went about approaching it?
When you say demonstrate capacity, what can you just help me can you help clarify for me what you mean? I mean, because there are like a whole set of, I think AHRQ or IHI, I think it's IHI, has a whole set of like, care coordination measures, like how to demonstrate that you're accomplishing these things and you're doing it well. Or are you talking more about, is that what you're meaning, like sort of the efficacy of the care model itself, or are you talking about kind of capacity planning for this? Getting to Andy's point about like having kind of the best model for, care team structure.
Yeah, I'd say both. From the perspective of demonstrating efficacy, as we're entering these value-based partnerships, how do we go about, demonstrating that we're doing a good job at providing care management and care coordination? And I would imagine that would really rely on the terms of the contracts that we enter into. But certainly also interested in seeing resources.
I think a lot of times what's used in that case, I'll send us out to the whole group. I'll send the resource that talks about how I think it's an IHI document. I got to find it though. But a lot of times they look at things like utilization patterns, kind of post care team intervention to kind of see, things that you would expect, like, readmission rates and medication adherence and things like that. So there's some definite things that can be pulled out of claims or utilization, data that can help to identify that. Obviously, in the world that we live in, work in, lots of things around patient engagement, being able to use, being tracked now that help tell this story from the patient's perspective. So there are quite a few of those things that have been sort of articulated and enumerated out that I'll make sure to get out to the whole group because I think it would be helpful. I'm sorry, I'm completely lost. I got so focused talking about that. And the second piece of it is around
empanelment, basically. We're wondering, how do you go about developing any sort of empanelment strategy when you don't have a clear idea of I mean, we can't even answer like what % of an FTE focuses on care coordination. So obviously we would have some investigation to do within our own network, but can you talk at all about like balancing, how do you go about impaneling patients when care coordination and care management is just one component of a much larger role?
Yeah.
So, you can take a stab, Amanda.
No, go ahead. No, it might have been me, Andy. It's Pam. We have worked with networks who, as part of, that's a common problem. Care coordination is shared amongst another role, and where they started, I think we would say they didn't try to go too far into impanelment without assessing their capacity more specifically. So they developed a survey with us where it was a detailed and role-specific survey where they asked each of their members to share, they would set a definition for care management or care coordination, the type of role and the percentage of that staff person's time that was spent conducting those activities, and sifted through that data as sort of setting their baseline so they could communicate their capacity to payers, but they were pretty far along the sort of contract negotiation spectrum there. But
okay.
Andy, was there anything you wanted to add to that?
Just that certainly when you're describing or talking about a network, I think one of the real critical elements is its ability to drive towards some level of standardization around what you're trying to do as it relates to risk stratification and then the corresponding care management approaches. Otherwise, it just gets really muddy to be able to go into negotiations. And I was out with you guys not that long ago, and we kind of talked about that. But the second thing is, and I kind of alluded to this earlier, is anybody's first pass at balancing that empanelment based on a weighted risk-adjusted or risk-stratified population is going to be a stab in the dark. And your best strategy for getting started is to get started, to run, take the whole patient population to the best of your ability, put them into risk categories, and then look at the variation and try to come up with the ratios at each level. So somebody might be dealing with all very high-risk patients and only have 250 patients on a panel, and then somebody else might have all low-risk patients and have 3,500 patients on a panel. But you kind of, for better or worse, again, there's no secret sauce. There's no magic, formula out there yet that's really emerged. It's kind of working it backwards through what are people handling now. I think having some sense of maybe which care teams might be kind of optimized might be a good place to look, because if a care team is already operating efficiently and you can look at what their allocation is, there's probably something, some information to be gleaned there. And then kind of continually proving it out over larger and larger data sets. So you're going to start with maybe one health center and then add others, and kind of adjust as you go. And ultimately you'll get there. And quite frankly, that's a really valuable piece of information to have when discussing your processes with your payers.
Awesome. That helps. Thank you, guys.
Yeah, and I think just on that point, too, now apparently we're going to have all three Starlings weigh in on this question. So well done you, Megan, for asking a question that got all three of us to sit up a little straighter. Andy raised this issue, but it's really important, because when you sit down to talk to those payers about the payment model that you need to support these interventions, you really have to have a good idea of what the fully loaded cost of your coordination program is going to be. And being able to sort of talk about that at scale, if you're negotiating over a group of providers who might all have a slightly different approach, it is really important to have some level of standardization and some level of consistency. So it is the number of FTEs and the type of FTEs that would get baked into that equation, but there might also be other types of costs associated with the care management that you'd want to be careful about, really making sure that you understood so you could articulate it in a way that was supportive of the payment model. So, if there was a magic formula for this, Starling advisors could just, all three of us could retire because we could just sell a turnkey solution to everybody. But it is, it so much of it depends on who the patients are and to some degree what your local resources are. Because some groups might opt, to build into their care model. Andy's probably going to kick me under the virtual table for bringing this up for the millionth time, but things like e-consults and clinical pharmacy might be more important as part of your care team and your care model in some parts of the country or some parts, regions of your state, but less important in others. So it really is about the totality of being there, of really looking at the full spectrum of what you're trying to accomplish. But thank you for the question.
Yeah,
and I think this is Tricia from DCPCA. I think our biggest challenge is on that standardization issue and how do you move a network to you have to be able to articulate some kind of product to the MCOs and, without that standardization, it's hard to say you have a product that's going to do anything different than what you're currently doing, within the health centers. So, yeah, if anyone has the wand that magically makes everyone agree on a care model and a data platform, I'm in.
We are too.
We'll get right on that. All right, so we've talked about this, but, just to kind of recap on the strategies, we've talked about this a lot, the expanded care teams, making sure that care coordinator skills match what the model is, making sure that we think about empanelment and population health management because they really are the linchpins in all of this. Thinking about how clinical decision-making tools and services help provide a framework for some of the interventions, but also help to support some of that consistency and scalability in the models that we were just talking about, and thinking through how evidence-based guidelines and provider education and infrastructure can help support that as well. And then some specific strategies that we know that safety net providers have really looked at as they've thought through this approach around risk management is this idea of what role do sort of specialized services play, things like referral management and authorization, and then some other specific examples, a little bit like we talked about already, the ED diversion, clinical pharmacy, and a hospital contract development. So thinking about how specific functions might fit into your care model to create efficiencies and support, better patient care. Sometimes it's important to think about how to insource those so that we have more control in our system and can help, better manage cost and quality. So that's it on that. And I can't believe how early we finished given how talkative everybody was today. Just as a reminder, the next session will be a session where we really sit and listen to all of you, which is, an opportunity for each of you to sort of talk through how what you've thought about and learned about over the course of this learning collaborative. I have 14 more slides, Andy is saying. How do I have 14 more slides? I don't see more slides, Andy.
Oh, okay.
Sorry, I don't know. It's not progressing.
Oh, no, you're good. All right, I might have been looking at the wrong one.
Andy was giving me a note that I had 14 more slides, and I thought that I was having problems with my advancement again. I'm having a morning, you guys. Thank you for sticking with me. Anyway, so the next session is really going to be focused on us listening to you, and hopefully we can have some more conversation like the ones we've been having today, where we really think about what are people doing in these areas that could provide us insight into our own strategies and approaches. So with that, I think, AJ, are there any other sort of logistical things that you need to coordinate with the group on before I let everybody get another 20 minutes back in their day?
Yeah, so real quick, everybody, be on the lookout for a feedback form that we'll be sending out from SNAC, which is just kind of going to be for our sake. We're going to be compiling a report after the end of these sessions, which is going to kind of give us an example from all of your organizations of what you've learned from the VLC and what we can use moving forward and how it's been benefiting for you and how it also is going to benefit the safety net in general moving forward. So look out for that. I'll be sending that out in the follow-up email I'll be sending out. And yeah, just as Amanda was saying, be sure to send out, I'll put the dates out, but be sure to send out those final PowerPoint presentations for session 6 to Samantha and I. I think the date is by next Thursday, and I'll be sure to put that out in the email. So that's about it.
Thank you, and thanks to everybody who's taken the time to meet briefly with the folks from the Starling team in advance of that. It's also just purely selfishly, we like to hear more directly one-on-one from you guys about what you're doing and how you're doing it. So so thank you so much for that. And with that, we're going to give everybody back a little bit more time in their day. So get back to your emails and your burning issues, and we will see you guys all again in 2 weeks. Thank you.